Welcome to the deep dive. Today we are tackling a really serious topic, one that requires a lot of clinical focus, sexual violence. And this covers a huge range, everything from unwanted advances, trafficking, all the way to, well, organized rape and conflict and sexual homicide.
It's definitely heavy, but absolutely critical for anyone in healthcare. Our goal today is pretty straightforward. We're doing a deep dive into Chapter 29, the one on sexual assault, from Varcarolis' Foundations of Psychiatric Mental Health Nursing. We really want to pull out the core psychiatric ideas, the biology involved, and the therapeutic approaches you need to know.
Yeah, getting those essentials quickly. And when you look at what the source says about the nurse's role, it's central. It emphasizes that nurses aren't just there for holistic care, which they are, but they're also key players in preserving evidence.
Exactly. And that evidence piece is so important for both the medical side and any potential legal side. It links the two.
You need to be thinking about both. And the scale of this, source points out rape is the third most common violent crime in the U.S. That's right after aggravated assault and robbery.
That really tells you how likely it is you'll encounter this in your practice. So, okay, let's maybe start by getting some clear definitions down. The text distinguishes between attempted rape, threats or intent that didn't succeed, and completed rape.
Right, and the definition for completed rape, the standard one, now from the FBI, they revised it. It's defined as penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without the consent of the victim.
And what's really interesting that they're the two big shifts. First, it specifically includes crimes against men now, which gives us a clearer picture statistically. And second, they removed the word forcible, the idea being that penetration without consent is force. The term was kind of redundant.
That makes sense.
Yeah.
And we need to address that myth, the one about the offender always being a stranger lurking somewhere. The source material is clear. That's often not the reality. It highlights specific relationships.
Absolutely. Like spousal or marital rape, penetrating a partner without consent. Historically, unbelievably, this was seen by some as a marital right. It took until the early 90s for all 50 states to actually outlaw it.
Wow, the early 90s. Then there's statutory rape, which is a legal thing. Basically, a minor cannot legally consent, doesn't matter who initiated it or if they seem to agree. The age varies, usually 16 to 18.
Right. But the one that comes up most often, according to the text, is date or acquaintance rape. The perpetrator is someone the victim knows. And the numbers are...
Well, they're shocking. Up to 1 in 4 college women report this happening.
1 in 4. And it gets even more complex when you factor in drug-facilitated sexual assault, where intoxication means the person literally cannot consent. Often they don't even remember it, which makes reporting and therapy incredibly difficult. Yeah, the amnesia is a huge factor, and we need to know the drugs involved. The source mentions GHB, gamma-hydroxybutyric acid. It can have a salty taste, causes deep sedation, euphoria, and that memory loss.
Okay.
Then there's Rohypnol, or flunitrazepam. It's a benzodiazepine, like Valium, but about 10 times stronger. Causes sedation and amnesia, too.
And the third one is ketamine. That one's a bit different, right? It causes more of a dissociative state.
Exactly. Like a dreamlike feeling, detachment, but also complete compliance. It's an anesthetic, after all. This whole issue eventually led to specific legislation, the Drug-Induced Rape Prevention and Punishment Act in 1996.
Okay, so if we look at the bigger picture, the epidemiology, the numbers are really stark. The source cites 2014 data showing lifetime rape prevalence is about 19.3% for women and 1.7% for men.
19% for women, that's almost 1 in 5. And when you look at who assaults females, it lines up with what we just said, mostly not strangers. Almost half are acquaintances, and another 45% are intimate partners.
So the care involved often has these really complicated relationship dynamics tangled up in it.
Definitely. And for male victims, while it's a smaller percentage overall, they're more likely to face multiple attackers and experience more severe physical trauma. Often happens in locked institutions, the text notes. And they might hide their emotional reactions, but they absolutely need and benefit from the same level of care.
We also have to be aware of specific vulnerabilities highlighted in the data. Females identifying as multiracial actually have the highest lifetime risk, at 32.3%, followed by American Indian and Alaskan Native women.
And that's not just a number, it means tailoring your approach. You need culturally sensitive, trauma-informed care as a baseline, especially with these groups. Plus, individuals with disabilities and older adults are also frequently targeted.
The source also mentions stalking briefly. About 15% of women and nearly 6% of men have experienced it, and it can be linked to assault.
Right. And before we get into the clinical side, there's a key legal point. VAAWA, the Violence Against Women Act of 1994. It mandates states have to pay for, or at least reimburse, the cost of sexual assault forensic exams.
And that's huge because it means the victim can get that crucial exam and care regardless of whether they decide to report to the police right away or ever.
Exactly. Access to care decoupled from reporting status. Okay, so shifting to the clinical picture. The psychological impact is, well, immense. Survivors often initially meet criteria for acute stress disorder.
Which can then develop into PTSD, post-traumatic stress disorder.
Right. And along with that often comes major depression, anxiety, low self-esteem, sexual dysfunction, even chronic physical symptoms, somatic complaints. The trauma can also trigger these really profound psychological defenses.
Yeah, the book defines two key ones you might see. Depersonalization, that's feeling detached, like you're outside your own body or mind, watching things happen.
An out-of-body feeling. And then derealization, where the world itself feels unreal, distorted, maybe dreamlike or foggy.
Hmm.
Recognizing those is really important for understanding the patient's immediate experience.
Absolutely. And because it's so complex, specialized care is really the ideal. That brings us to the sexual assault nurse examiner, the SANE.
Yes, the CNCN. This is an RN who's gone through pretty rigorous specialized training. They know how to do both the medical evaluation and the forensic legal evaluation, collecting evidence properly. They can even act as expert witnesses in court.
And they usually work as part of a team, right? A SART.
Exactly. A sexual assault response team that's multidisciplinary, includes the C, maybe physicians, attorneys, social workers, advocates. It's a coordinated response.
Which is vital when you're dealing with what the text calls a forensic patient.
Yeah.
Basically, anyone whose case might involve the legal system.
Okay, so let's apply the nursing process, starting with assessment. This initial evaluation is incredibly delicate. If it's not handled well, you risk what's called re-victimization.
Where the process itself feels like another assault.
Precisely. So the nurse has to be meticulous, but also incredibly sensitive. The source outlines 5 key areas to assess. First, their level of anxiety. Is it severe? Panic? Because if it is, they simply can't process information or solve problems effectively right then.
Okay, anxiety level first. Second,
Coping mechanisms. What are they doing right now? Is it behavioral, crying, pacing, maybe using substances, or cognitive? Are they thinking things like, at least I'm alive, or maybe blaming themselves? You need to know how they're trying to manage immediately.
got it. Third area,
Available support systems. Who came with them? Are they actually supportive? Sometimes partners or family can unfortunately be judgmental or add to the chaos. You need to assess if the support is actually helpful.
that's a really important nuance. Fourth,
Signs and symptoms of emotional trauma. This absolutely includes screening for suicidal thoughts. You have to ask directly, clearly, don't just hint around it.
direct questions about self-harm. And the fifth area,
Signs and symptoms of physical trauma. And remember, bruises might not show up right away, so it requires careful inspection, palpation, looking for injuries that aren't immediately obvious.
and throughout this whole assessment, communication is key. The source stresses, avoid why questions.
Absolutely critical. Asking, why did you walk home alone, or why were you drinking, implicitly shifts blame onto the victim. It reinforces shame. It's countertherapeutic.
So what details do you need right away?
Only what's necessary for their immediate physical care and psychological safety. You don't need the whole narrative right then. And you have to provide constant psychological support during the physical exam, especially the genital exam and evidence collection, the swabs, hair samples, blood draws. That support helps reduce that feeling of re-victimization.
Okay, the SARE exam itself follows specific steps, right? Best practices.
Yes, the source outlines 5 main steps. 1, a full head-to-toe physical assessment. 2, a detailed genital examination. 3, careful evidence collection and preservation chain of custody is vital here. 4, meticulous documentation. That includes written notes, but also photos or body maps to record injuries accurately. And 5, providing necessary treatment, discharge planning, and arranging follow-up care.
And in terms of immediate medical treatment, what are the priorities?
2 big ones. Prophylactic treatment for STDs is offered. And assessing for pregnancy risk. The book cites a statistic: almost 3 million women in the U.S. have experienced a rape-related pregnancy. So offering emergency contraception, if it's appropriate and desired, is standard practice.
Wow, 3 million. Okay. And the nursing diagnoses reflect this.
They do. The immediate priority diagnosis is rape trauma. That focuses on the patient's state right after the assault, physical and psychological.
And for the longer term.
That's rape trauma response. This addresses the ongoing, sometimes maladaptive reactions. It's about the disruption to their life and the process of trying to reorganize and heal.
Okay, so moving into interventions, what's the core approach?
Well, beyond the medical necessities, the most powerful thing you can do is provide non-judgmental care and emotional support. Really listen. Let the patient talk if they want to, don't push if they don't, and maintain confidentiality strictly.
And there's a key therapeutic principle mentioned.
Yes, helping the survivor separate vulnerability from blame. This is huge.
Can you unpack that a bit? Vulnerability versus blame.
Sure, someone might have made choices that, in hindsight, increased their vulnerability, maybe walking alone late at night, maybe drinking too much, but that never makes them to blame for someone else choosing to assault them. The blame lies solely with the perpetrator.
Right, so acknowledging vulnerability helps them think about future choices they can control without taking on blame for what happened. That seems crucial for regaining a sense of agency.
Exactly. It helps them focus on what they can do moving forward, which is empowering. We also need to actively challenge those cultural myths that contribute to victim blaming. The source highlights a couple.
Like the one that rape is about sex.
Right, myth. Rape is about sexual gratification. Fact. Sex is the weapon used. The act itself is about violence, aggression, anger, power, control. It's not about mutual desire.
Okay, that's a critical distinction.
Yeah.
And the other myth.
Myth. Rapes are impulsive acts committed by strangers in dark alleys. Fact. Most rapes, the source says 69%, are committed by someone the victim knows. Often they're planned, not impulsive, and over half happen in the victim's own home or the assailant's home.
So the reality is often much closer and more calculated than the stereotype. Given the likely anxiety and maybe disorientation of the survivor, how should discharge planning be handled?
Very practically. Provide clear, simple, written instructions. They probably won't retain complex verbal info. Give them specific referrals for counseling, medical follow-up, maybe victim compensation programs, online resources. Make it easy for them to take the next step when they're ready.
And follow-up is essential.
Non-negotiable. The source recommends follow-up visits at least 2, 4, and 6 weeks after the initial exam. You need to reassess their psychological state, check on STD status again, and confirm pregnancy status. It's ongoing care.
Okay. And what does recovery look like according to the text? How do you know someone is moving towards healing?
Recovery is generally seen as returning to their pre-rape patterns of living, sleeping reasonably well, anxiety is manageable, maybe mild, not overwhelming. They have a more positive view of themselves again, and those severe somatic symptoms have lessened or gone.
So, thinking longer term, what does the journey look like for everyone involved?
Well, for the survivor, ongoing psychotherapy, individual or group, is often vital for processing the trauma and minimizing long-term effects like PTSD. But the source adds a kind of sobering point about perpetrators.
Which is?
That while therapy is what's needed for them to change their behavior, most perpetrators simply don't acknowledge they need it or have done anything wrong that requires change.
That lack of accountability is a huge barrier. Which brings us to our final thought. Something provocative from the source material to leave you, our listener, with.
Yeah, the text points out that there's this persistent underlying cultural myth, the idea that women are somehow the property of men. And this outdated belief actually prevents some people, even family or friends, from truly empathizing with the deep emotional wound of sexual assault. They might minimize it or not grasp its severity.
Which really highlights why the nurse's role extends beyond just the patient. You often need to support the family and friends too, helping them understand the trauma.
Exactly. Especially in communities where those older myths might still hold sway. Reducing the shame that can surround the survivor and sometimes engulf the whole family is a crucial part of facilitating long-term healing.
That really broadens the perspective on what comprehensive care looks like in this context. It's a critical insight. Thank you for joining us for this essential deep dive today.